Guys, we're in the middle of the pandemic and these are trying times. It's hard on our mental health, our mental state. And this is why I love our sponsor today, BetterHelp. They're the largest online counseling platform worldwide. They change the way people get help with facing life's challenges by providing convenient, discreet, affordable access to licensed therapists. BetterHelp makes professional counseling available anytime, anywhere, through a computer, tablet, or smartphone. It's brilliant. Sign up today. Go to betterhelp.com/solvinghealthcare and get 10% off sign-up fees.
COVID has affected us all, and with all the negativity surrounding it, it's often hard to find the positive. One of the blessings it has given us is the opportunity to build an avenue for creating change, starting right here in our community. Discussing topics that affect us most, such as racism in healthcare, maintaining a positive mindset, creating change, the importance of advocacy, and the many lessons we have all learned from COVID. If you or your organization are interested in speaking engagements, send a message to quadcast99@gmail.com, reach out on Facebook at Quadcast, or online at drkwadwo.ca.
Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved. Well, guys, Nation, yes, we are back with a very important episode with the one and only Dr. Tracy Hoeg. We brought her back. She is clinical epidemiologist. She's expert in public health, and she's just been at the forefront in this discussion with, our approach to kids, whether it's masking, vaccinations, myocarditis. And the beginning of our conversation, I really enjoyed it. We talked about what the risk is to our children. What is the actual risk of our kids getting ill and succumbing to COVID, and also putting it in relation to other conditions, which I think adds to the perspective big time. And I think you will thoroughly enjoy this conversation. Just a huge fan of the work she's doing. And I'll be honest with you guys, like it's a tough landscape to navigate through, talking about, handling COVID for our children, because, there's a lot of cancel culture out there and certain topics that seem to be taboo for no good reason. And, but, for me, I got to say the line that the sand always is my kids. And if you can't stick up for them, I don't know who you can stick up for. Before jumping into it, I just got to give some love to Solving Wellness. We're growing. We're up over 210 members at the time of this. You know what I'm saying? And it's our way of combating clinician burnout, compassion fatigue, all these things that we're seeing peri-pandemic, pre-pandemic as well. You go $99 a year or $9.99 a month for online workouts, yoga, nutrition advice, cooking classes, mindful meditation, the works, how we manage stress, productivity tips, all under one platform. First month is free. Check it out. solvingwellness.com. You will not regret it. Change the boogie, yo. Anyway, without further ado, let's bring on Tracy Hoeg. Quadcast Nation, we're bringing back the legend, epidemiologist, super well referenced and amazing advocate for our kids, Dr. Tracy Hoeg, aka Dr. Tracy Hoeg. Sorry, how do you say it again, Tracy?
Hey.
Yeah, exactly. That's how it must have sounded the exact same. But thank you so much for coming back on the show.
Thank you for inviting me. Sorry. Yeah. No, good job. And I'll say your name right this time too, Kwadwo. I got it wrong last time. So now. Oh my goodness. No, I think I've been throwing all of us off with that pronunciation, but thank you, honestly. And I'm going to say this out of the gate, the advocacy that you've been doing these days for our children, that voice of reason, I can tell you it's something that's helped me sleep better at night. And I just want to really commend you, because it takes a lot of courage in this climate, and I'm trying to
I'm trying to go follow right behind you in terms of doing what's right for our kids. So I really want to commend you for all this.
Yeah, well, that means a lot coming from you, and it takes a team of people because you inspire me too. And I think, the more we're seeing people speak up and, make reasonable statements and, put what we're doing into context. And, I think that we support each other a lot. So thanks for doing what you're doing.
Oh, man, absolutely. And I think a good place to start, Tracy, was, the risk of COVID with our kids, because, we'll talk about, not only the risk of COVID, but also the concerns about vaccination. But I think people have a tough time really articulating what the danger is to our kids. You know what I mean? Like really as having that risk assessment.
Yeah. So it's a thing that's hard to understand risk, so I can say to you per infection, and this is from international data, that the chance of a child being hospitalized if they're infected is 1 in 500 to 1 in 1,000. Now it's even less than that for kids without medical comorbidities. It's higher than that for kids with certain medical comorbidities like obesity and immune compromise, neurological disorders. But then, people sort of they tend to understand risk in when you compare it to other risks that we're more used to. So like, for example, the risk of your child dying from COVID is 10 times less than the risk of your child dying in a motor vehicle accident, or it's, depending on the age, it's 2 to 12 times less than them drowning, so I think people understand those types of risks better. And then comparing it to influenza, the risk of dying from influenza on an annual basis, except for this last year where there wasn't much influenza, but in a usual year is similar to the risks of dying from COVID-19. Depends on the database, is a little bit more, is it a little bit less? But, and then we talk about these long-term consequences of COVID-19 too. And in the beginning, we didn't really understand how often kids were suffering from long COVID. And now we have a few larger studies. One from the UK recently showing that there was actually no difference between the kids that had COVID and the controls in terms of long-term symptoms. So that's not to say it doesn't exist. It's just to say that when you look in a large database of kids, you can't even detect it. And so it probably happens. I think we know it happens. It's just much less common than we initially feared that it was or thought it could be.
Mm-hmm. Yeah. And it's a great point that you bring up, Tracy, because the numbers, it's hard to put those in perspective for people. Like when you do say your risk of hospitalization is 1 in 500, 1 in 1,000. But when you have it in relation to something that's like tangible, your risk of influenza, risk of dying in a car accident, risk of drowning. And I think this is maybe one of if we're going to look back at this and talk about how we would approach things differently, maybe that's the conversation and the way we communicate it to the public.
Yeah. And I would just add also that at least for kids, it was like, per the CDC data, it was the 5 to 14-year-olds were also more likely to die of suicide, And so then when we consider that the pandemic increased the risk of suicide, increased the rate of mental health disorders, like we also have to have the discussion about if what we're doing increases their risk of dying, to protect them from one disease, are we increasing the risk of dying from something else? And, we can talk about that with like the doubling of the rate of weight gain among kids that we saw in the United States. Like that is not maybe now, but later in their life, that's going to increase their risk of premature death, of, lots of health problems. So we also haven't been having that discussion, like a serious discussion about the trade-offs of what we're doing, because there's been hyper focus on this one disease. And, I think a lot of people, scientists, public health people, were thinking, well, once we kind of have an understanding of COVID, after the first 4 to 6 weeks, and, maybe we can start looking at risks and benefits. But it's like that just became taboo. It was like, no, we can only talk about COVID because otherwise you're a Republican,
Oh my God. It's so true. I don't know. Like that's honestly, Tracy, that was the part that was scary for me was when it became taboo to talk about the trade-offs. Like there's no job or profession or where you can't think that whatever you decide, you're not going to have that consideration of the trade-offs. And the thing that was driving me nuts is it became abundantly clear early on that you're risking our kids' mental health from our measures, your overall well-being, the weight gain that came a bit later. And especially when you recognize what the risk factors of getting sick from COVID is, you know what I'm saying?
Like totally. Oh, exactly. And any parent, they could see this immediately. I mean, I think most parents could see this. Like in my own kids, it's like they're out of school for 4 weeks and suddenly they've like gained 5 pounds. I'm like, oh my God, I mean, everyone could see this happening. Like their lives are just shut down. So the fact that it wasn't okay to talk about it, it was like, well, the people deciding it wasn't okay. I don't know. Did they not have kids? But yeah, I mean,
you do wonder, like, maybe their kids are older or what have you, but usually you relate to your current circumstances, and like you and I are in the thick of it with our kids, and you can't just ignore this. Like it's right in front of you. And
you cannot ignore kids, like, giving up their lives. And the thing is now, the thing that's so frustrating about it is now it's like the whole reason that we were saying, okay, well, it's understandable that we have to minimize, transmission from kids. Everyone felt like bad for teachers because they didn't want them to be exposed to unnecessary risk. Right. And so then we found there's less COVID spread in schools and in the communities. That was one thing. But now teachers and adults all have access to vaccines. And I in the United States and in Canada, it's like, well, I see that schools are open, but we're like doing even more mitigation strategies among kids than we were last year in a lot of places. Like I saw it was Ontario, right, where kids, like, they're not allowed to talk to each other at lunch.
Crazy. I just found this out this weekend, and I was like, what? They can't speak at lunch? Like, first of all, Tracy, one of the things that we should be absolutely celebrating with this pandemic is the fact that the kids have been, like, relatively speaking, have been protected. They're not, like, you know what I mean? Like, this is such a huge relief as a parent, as looking, like, out forecasting the impacts of the pandemic. Like, this is something that we should be celebrating. Then the fact that it was clear, like, thanks to your study and others, that there wasn't massive transmission happening within the school. Like, it wasn't spreading like wildfire. You know what I mean?
Right.
And the fact that, teachers weren't getting like crazy, like all these things. And this is before the vaccine. And then we had the vaccine. We had that much more knowledge. We had that much more community, like less community spread because of our immunizations and so forth. Yet we're still acting like nothing has changed, which to me is baffling. Like, learn.
I know. And it's like, with regards to this one specific issue with talking in lunch, and I would also bring up like masking outdoors. Like in our Wood County, Wisconsin study, the kids were eating lunch indoors and they were actually talking to each other. And we, had minimal spread in that study, very low. It was 7 of the cases out of the 191 that came into the school were spread at the school. Okay. And the kids were not masking outdoors at recess. We can get into masking and the efficacy of that, which is a whole, different topic. But now it's like, what kids are just being made to be afraid by having policies like that, by saying like, it's not even safe enough for you to take off your mask outside. It's not safe for you to touch each other. It's not safe for you to talk to each. I mean, I don't know. What are the implications of what we're doing to them? And so, in terms of their fear of, how they're going to impact others and, seeing themselves as vectors of disease. disease. And we can contrast this with what's happening in Scandinavia and actually most of Europe right now. I mean, in Scandinavia, I've mentioned this before, but they've never masked kids 12 and under. And then, now there are no restrictions. There's no restrictions in Norway, Sweden, and Denmark. They just
right now it's zero. Like zero.
Yeah, zero. I mean, and I know I have a bunch of contacts in Denmark, and I think there's, agreement that, they may start mitigation strategies at some point if necessary, like curtailing the size of large indoor events. And, they always have paid sick leave there, which is great. But, I don't see them starting to mask kids on 12 and under because they've never needed to do that. And right now, their hospitalizations are not above where they were when they lifted all the restrictions. They've just been pretty stable. Cases are increasing, but, that's not unexpected.
So what I'm hearing from you, just because this is new information a little bit for me, the Scandinavian countries, including Denmark, never masked their 12-year-olds and younger. They've eliminated all restrictions at this time. Yes, there are increasing cases. Hospitalizations don't seem to be impacted at this time. This is, by the way, October 26, 2021. But and the spread within schools were similar to the papers that we know about. That as far as there wasn't crazy.
Probably the best study we had about the spread within schools was actually from Norway, and it was very similar to the secondary attack rate that we had in the Wood County, Wisconsin study, the North Carolina study. So that's been pretty similar. Now I will say with Delta, I know looking at Australia data that it did look like higher transmission rates in the schools. So, like you brought up before, we do have to celebrate the fact that the people, those who are at highest risk of this disease, there's access to vaccinations now. So even, Delta does seem to be more transmissible. I don't think there's any way around that. It does appear to be, but now we have vaccinations that are quite effective at preventing severe disease, for those who are most at risk. So, and I think that's why, Scandinavia is like, this is the COVID end game. Like, is it going to get better than it is right now? I don't know. I mean, there's increasing immunity the more people that get COVID. So maybe it will, but I think that they're looking at the trade-offs too. And they're like, especially kids thrive with routines and predictable lives and, getting an actual education, and the whole society thrives because the kids are in school and the parents are not, worrying about what's happening to them. And, we've touched on this in the last podcast, but, everything really does need to center around what is happening, with the kids and the most vulnerable, because if they're someplace safe during the day, they're learning, they're happy, then, people, adults, parents, grandparents, they go on with their lives, their work, productive members of society. So, normalcy is undervalued, I think, in the United States and potentially in Canada too, though I'm not Canadian. I can't speak to that as much, but,
Oh, and by the way, congratulations. I heard your husband is a full-blown citizen now.
That's right. He just became a citizen of the United States today. Yes. So now I'm allowed to say whatever I want on your podcast. And Twitter. I'm going to become totally unhinged now because now I don't have to worry about that.
That's amazing. Gloves are off. But you make really good points that I think are worth highlighting. Like, yes, you got to acknowledge the other side too. Like, yes, Delta more transmissible, and in this group, luckily they don't. And we had this with Martha Fulford saying, like, with Delta, the kids aren't getting more sick as a result.
That is key.
Important to highlight too.
That's right. I mean, you'll see more hospitalizations as a result of the fact that there are more cases. But, now the hospitalizations, at least in the United States, among kids is falling, and that, the cases are also going down. So overall, across the whole country, despite school being in session. So.
Yes. Yeah. So reassuring. And, and it comes, once again, comes back to that kind of we talk about the risk benefit, risk assessment, and some of these other interventions that we're talking about. So whether it is masking the kids, and I mean, for me, it's what I get a bit uncomfortable with is the masking of the really, really young kids when it's, you're trying to impact their linguistic skills, and they're like, those are very formative years for how their ability to communicate and stuff. But, actually, maybe I should ask you straight up, like, I see it on Twitter all the time. I avoid commenting because it's so dark. Like, it's such a scary world right now. But is there data that you're aware of that supports masking of our youth in general?
Okay, so this is a really good question. So recently, the CDC, MMWR had two studies that came out that both were in support of masking kids in schools. But unfortunately, so these were pretty flawed studies in the sense that they were missing a lot of critical information to determine exactly what impact the masks had. So like, for example, there was the Arizona study in MMWR, and they found that there were fewer outbreaks in the schools that had mask mandates, but they actually didn't account for the fact that in the community, so it was in Maricopa County. So Maricopa County was the county without the mask mandates, and they actually had a much steeper rise in their cases among the entire community during the course of the study. And so that was like the most key thing that they didn't control for. And then so we're still trying to get information on this. Actually, I'm working with a couple people to get answers from the authors about this, but they may not have controlled for the number of days or hours of contact between the kids and in school. But I would just say that when you look at cases in schools, historically, with the studies that we've done, less than 5% have come from within the school and 95% come from outside in the community. So what is happening in the community is the most critical thing in terms of the amount of cases in the schools. And if you are not controlling for what's happening in the community, you cannot say anything about the effect of the masks in the schools, because all of these studies, they look at the overall cases among the students. And so that was similar to the fact that, like, there was another study, including multiple districts across the United States, where they weren't actually able to control for the community vaccination rates among the adults. So they also found a benefit of masking without controlling for the adult vaccination rates in the community. And they didn't control for the fact that there was a faster rise in more steep rise prior to the study of cases among the kids before the school even started. And then the study only went 2 weeks. And so it was like both of these studies, they had the feel of like they were cherry picking this very like brief window of like, we're going to find some difference between these two masked and unmasked schools, and we're going to present this as data, and we're not going to control for the key factors that, come from the adults and the communities in terms of like the amount of cases that you see actually in the schools. So those are two studies that are being cited by the CDC right now as like, incontrovertible proof that masking works in schools, but we have no randomized control trial. And then our study from MMWR is also being cited as evidence that masks work in terms of preventing transmission in schools, but we did not have a control group that was not masked in our study. So we can't comment on how effective masks are, just like any other part of our mitigation. We don't know what worked and what didn't work. And so really you need a well-designed, control study. So I'm actually working right now with 2 school districts that are right next to each other in Fargo, North Dakota, one that has a mask mandate and one that doesn't. So far it's been interesting that the one without the mask mandate has had lower case rates than the one with the mask mandate, despite actually having lower vaccination rates in the community, and despite actually doing more testing, like more on-site testing. So those results are to come. I hope that I can convince MMWR that this might be a worthy thing to publish, once we get it written up. But it's been interesting to watch, because so far I don't think that we have good evidence in kids showing that like mask mandates or mask requirements are doing much. And part of that might be because, it's unrealistic to think that kids are able to wear a mask correctly all day, every day, and not expose each other. I mean, obviously they take it off, they breathe around it. I mean, and most of these kids are wearing cloth masks, and we already saw in the Bangladesh randomized control trial that the cloth masks actually didn't work in terms of preventing, laboratory confirmed SARS-CoV-2. So, and they only the surgical masks appeared to work in the context of distancing and education and other things to prevent SARS-CoV-2 among people who are over 50 years old. Mm-hmm. So those are not kids. Right now we don't have good data showing that masks, decrease the risk of SARS-CoV-2 among kids. We have a Georgia study that looked at the masking in kids in schools. This was the MMWR study. They found no difference when controlling for the case rates. We have the school dashboard, Emily Oster's school dashboard. They also found no difference between student case rates in the masking and non-masking of the students and staff. I think we're at the point where we can say that, masking kids, it may have some small effect that we haven't, been able to detect it with any good study yet. It probably doesn't have a large effect. Otherwise, we would have seen it in those observational studies that I mentioned there from Georgia and the school response dashboard. But I mean, I think that a lot of people are not talking about the downsides of masking. So, the AAP and CDC are basically saying that there are not good studies showing the downsides of masking. Now, I will say that France came out with a nice observational study looking at downsides of masking, and they were talking about how they observed that the kids were not, the emotional impact of it, like kids were not smiling as much, responding to as much to each other's smiles. The participation in activities that involved physical activity was decreased. And then there were concerns about language as well. And I think that, especially parents of kids who maybe English as a second language speakers, younger kids who are just learning to speak. We know that kids who are blind actually do tend to develop language skills a little later. So I think, it's and kids with autism. I mean, I can only imagine if you have a child with autism and they're already afraid, to talk to people and make connections, that everyone has a mask. Of course, that's not going to be beneficial for them. So, I don't have all the answers in terms of all the downsides. But I think it's unrealistic to say there are no downsides. And, just when one considers, if you try to, bike or run or, do anything with a mask on, in terms of exercise, how uncomfortable it is, just that alone, I think asking kids to wear masks, while they're on the playground, playing soccer in PE, if we don't want kids to gain weight and we want kids to be active, what are we doing?
Yeah, it's almost like a deterrent. I mean, I still, I walk by, who's on the show have heard me say this before, high school nearby, and the kids are playing soccer with masks on outside. I'm like, what is this? Like we know,
it's so ridiculous. I mean, from the beginning, I have said my kids are not playing sports with masks on. I'm sorry, but and I'm like, hey, I'm a physician, and I refuse. And so our soccer club has always said, no, they're not going to play sports. They're not going to play soccer with masks on.
Yeah. I mean, you make some really good points in terms of the analysis. Like, yes, there's some data that as for the CDC, that's supporting that the mask might work on kids, but it's not on solid data. They're not controlling for community spread. And there's some other data to support that. We haven't seen much of a difference. And then logically, when we look at the Bangladesh study, when they had showing that cloth masks weren't making a difference. And honestly, most of the kids that you see wearing masks, they're not wearing surgical masks. And how they're putting it on, half the time you could see their noses. They're saturated. Like our kids in masks when they come home are disgusting. Yes. Straight up like do-rag, like
exactly. Like what are we even thinking that those masks are doing if they're wet and disgusting? And like I don't know, is that really preventing transmission? I don't know. And like the kids, my son, he's just like, we just take it off when the teacher's not looking, or we just what I mean. I don't know. I mean, it's just false sense of security too. Like if you've got a kid who's like really at high risk from COVID and you're like, I'm going to send them to school in like a tie-dye cloth mask, like, I mean, you should not think like they're not going to get COVID because they're wearing a cloth mask. Like, we saw that in the Marin CDC study, but the kids were all masking, and it was 55% of the kids in the classroom got COVID from the teacher. It's like they all had a mask on. So why are we saying that masks work so well, and and adults too, they shouldn't be thinking that like, the vaccine's not really that important as long as I wear my mask. Like, I don't know. I think our messaging with masking, we've gotten it all wrong. Like, and I think the WHO and the European CDC, they've gotten it much better. Like, masks may provide some benefit in areas of high transmission, and certain types of masks are better than others. And, more, acknowledging more uncertainty around it, rather than like, I saw the CDC just came out with this ad that looked like it was a 2-year-old in their crib wearing a mask. And I was like, oh, come on. I mean, this kid is like in their own home wearing a mask in their crib.
Yeah. Like, no. What it comes down to me, like I heard this on Vinay's show. He was interviewing an ethicist from Australia. And what he said really, I've hung on to. He said, the foundation of public health is trust. And part of establishing trust is really mentioning the stuff that you're not certain about, instead of being absolute about it and be like, as you said, we think masks have some impact. It's tough to quantify. And yes, we think, there's some uncertainty in certain spots, but by being upfront about it and not being shady and being absolute about things and then going back and forth on it, this is how you really create some distrust and hesitancy. So like, absolutely. just be real. Like most people will appreciate if you just, being authentic about some of the things that you know or you don't know.
Yeah, if you're not expressing uncertainty, it just feels like tyranny. And I mean, like, people are not stupid, people. I think that's been a problem with the CDC all along, is they're like, oh, the American people, they're so foolish. They don't know if like we're not including the most important details of everything we say, like, or if we're not acknowledging that we don't really know the answer. I mean, it's just. Yeah, I mean, there are definitely ways of saying like, maybe masks help and we don't really know the answers. And, you might consider wearing like an N95 if you're at high risk and you're not vaccinated, like things like that are actually helpful to people. Like public health is supposed to, provide a service to people, like help them. They're not supposed to be there to just like tell them what to do and you do this or else. Like, I don't know. That's not how I look at public health.
Well, I mean, we're in a completely different world and space right now. Like, I mean, so yes, we in terms of other, interventions we're doing to our kids, like the reason I reached out to you actually was on your paper on myocarditis. this is something that I think a lot of us have been. I'll be straight up with my people. Like I've been hearing about this for months and months, but way too scared to bring this up because of seeing people getting canceled. Sorry, guys, I'm getting number 3's coming in here. Come here. Come say hi. We're going to quickly say hi.
Hey, what's your name?
Hi.
What's your name?
What's your name?
No, what's your name?
I'm Tracy.
What's your name?
Oh, you can't hear because I got my headphones on. But what's your name?
What's your name?
No, what do I call you? Are you Ziki? Say your name.
What's your name?
Say your name. My name. Hi, Zeke.
Hi, Zeke.
Say hi, Tracy.
How are you?
Hi, Tracy.
She's asking you, how are you doing?
How you doing?
Do I need to put the show back on? What happened to your show?
I turned it off.
What are you going to do while I'm being interviewed? You're supposed to be. Sorry, 1 second.
Yeah, no problem.
Let's go watch another show.
Okay, I can.
Sorry about that. I knew it was going to happen. The nanny went to pick up the other 2, and Zeke made his way through. To be honest with you, this has exactly been my motivation of late, like thinking of my little ones. Like I got a 3-year-old, a 9-year-old, and a 7-year-old. And, I want to make sure that they're served right. So yes, you had this paper on myocarditis. And as I said, there was a lot of us were hearing about some of the concerns about this, but too shy to bring this up publicly. But maybe you could summarize what you and your authors found in the paper.
Yeah. So we in the paper, I mean, I'll just kind of, state like our motivations for doing this study. So, I mean, I have been very aware for a long time of how low risk kids are from COVID-19. So that's always been at the top of my mind, and I have kids myself. And so I've kind of always thought, well, if, when we get to a vaccine, obviously it's going to have to be incredibly safe, especially for kids without risk factors, in order for it to make sense in terms of, giving it to the kid itself in terms of the risk benefit ratio. So that's always been on my mind. And then, so when we started to hear about the possibility of myocarditis in young men from Israel, I believe it was April, then I was immediately concerned about vaccinating kids, especially boys. And so, I basically just started following along, I think like a lot of people did. And then I started hearing from contacts of mine in the United States about cases that they were seeing of myocarditis after the vaccine in boys. And this was May. And I thought, I had just no sense of how big this problem was, but I knew that this hospital system in Seattle had seen a large number of cases according to my contact there. And I thought, wow, this is really concerning, because this is a very low risk age group to begin with. And we have really no sense of how common this is, this post-vaccination condition. And so I kept thinking like, the CDC, they'll come out with some data, some study, and we'll all get the information we need. And, I honestly thought they were probably going to pause the vaccine just like they did with J&J because of the VITT safety signal that they found there. Or, I at least thought we would be getting more information, but then so the information never really came, although we did get some information in June from the CDC about their estimates of myocarditis. And so immediately it seemed like their estimates were low, but then it also was like the way that they presented the data was they were presenting it overall for all the age groups and boys and girls together. And when you do that, it's like you just water down the signal where we already knew this was like young men and boys who were getting the signal and after the second dose. So then, Allie Krug and John Mandrola and Josh Stevenson and I, we basically started just kind of looking at the VAERS database, and we came across the fact that there were all these cases in the VAERS database that of boys who had elevated troponins, who had abnormal EKGs and echoes, who were not listed under the symptom or of myocarditis, but they had all the criteria that met it. And the VAERS database is the vaccine adverse event reporting system in the United States. And so basically we use the CDC's same criteria in terms of objective evidence of myocarditis, but we included more cases from the VAERS database of children that had symptoms like chest pain that were actually not looked at by the CDC. And so we ended up finding, and then we stratified, very importantly, by age, by sex, so that we could find if there was any group that seemed to be at higher risk. And so we found that there was 1 in 6,200 risk of post-vaccination myocarditis in boys after dose 2. And that was in the 12 to 15-year-old age group. And then it was 1 in 10,600 for the 16 to 17-year-old boys after the second dose. And then what we did further was we compared that to their 120-day hospitalization risk, just like the CDC had done. But we divided it by, does the boys with comorbidities and boys without, because as we know that there's a difference between the two. And the difference of risk in terms of hospitalization from COVID, we found was about 4.7-fold difference. Now, I actually think the risk is probably bigger looking at some more recent data from the UK, but that's what we used. And so what we found was that even at times of high COVID prevalence, the boys without medical comorbidities were more likely to have a cardiac adverse event, that's what we called it, after the vaccine, then be hospitalized for COVID-19 over those 120 days. And that was without adjusting for the fact that 40% of those are incidental hospitalizations, like incidentally found COVID-19 diagnosis on hospitalization for something else, like, knee injury or
come in for your eating disorder admission and
right. Yeah, exactly. So that's what we found. And I mean, the point of the study was not in any way to induce vaccine hesitancy or to support that. The point of the study was, is there potentially a demographic or an age group where the risk benefit ratio for vaccinating them is not obvious, and that's what we found. Like it's not obvious in that particular group. And now we actually have, revised the paper, and now we're submitting again. And I will say that we were very close to getting it published in 2 of the world's top medical journals after they peer reviewed it. And there was quite a lot of debate about whether or not they were going to publish the study. But we did get a lot of feedback from those journals that was really useful. And we took that into consideration when we revised it and before we uploaded it as a preprint. And I will also say that immediately before we uploaded it as a preprint, the thing that convinced me that we should upload it was that the FDA had reported a rate of 1 in 5,000, which is higher than what we had found. And so I thought, okay, well, VAERS, the database we use historically does provide an underestimate of adverse events. And so I think that's what we had. And so then we felt more comfortable, publishing it. But I do think that in boys without medical comorbidities, giving the second dose particularly, is, might not be the smartest thing to do. I think we need to have discussions about giving just 1 dose. And that's why I was going to say we adjusted for in our revision is looking at the benefits of just 1 dose versus the 2 doses. And then looking at what about kids who have been infected before, like, from what we know from adult data, they have maybe in terms of prevention of hospitalization, if you believe the Israeli data, that they're 6.7 times less likely to get hospitalized than those who have been fully vaccinated. So it's, I think we need to be having discussions about do kids who have been infected, do they benefit? Especially boys, especially the second dose, are they benefiting from the vaccine, or are they more likely to be harmed? And then, how much benefit does one dose provide? And might that be something we should look at, and especially in terms of vaccinating otherwise healthy boys? So I've really been disappointed and frustrated, I guess, about the lack of open conversation about different options that might work better for children and for boys in particular. And I have two boys myself. And, I'll just say I haven't really, the only place I ever said this was in my column in Ultra Running magazine, but I myself had a cardiac reaction to the vaccine back in January when I didn't even know it was a thing. But I talked about it in there. And so, I am afraid that my kids are at higher risk because of the reaction that I had. And now my son's school, he's 13, is mandating him to be vaccinated by November 30th in order to get an education. And, he hasn't been vaccinated yet. And I would love to know more information about this condition. And I know many parents feel the same way. And I wanted to get vaccinated as soon as I could, because for adults, especially adults who haven't been infected, the risk benefit is I think very obvious.
Very clear.
And so this is a different story with kids. Especially in terms of can we just give one dose, and what about the kids who've been previously infected? And we're not having any discussion about that when we're talking about the mandates.
First of all, Tracy, I'm sorry that you're having to be put in this circumstance. It's one of my biggest fears, to be honest with you. When you want to do what's best for your kid, and we can have an honest conversation about it based on policy. And if you think about the VIT, we saw a harm signal and we adjusted policy as a result. We did that for our adults, and for some reason, and I should mention this too. Actually, I'll say this and then I'll mention it. For some reason, we don't seem to be as concerned about it for our kids when we do the math of that risk benefit ratio. And what I love too is that people that have sounded the alarm and say, hey, there's harm that could be done to our youth, our male youth. Here's a solution. Maybe we give a single dose. Maybe we do seroprevalence or check their antibodies and just offer a single dose after that. Or, you know what I mean? Like there could be some concrete solutions to this problem. And the fact that we're not entertaining it is baffling to me.
Yeah.
The caveat I would say is some of the people, and this is my experience just from talking to folks, and I don't, aside from one example I could think of, is that there doesn't seem to be evidence that the kids that have had myocarditis, that they've had significant long-term consequences for the most part. And I don't know if that's been your experience too, perusing the data or talking to some of your cardiology colleagues.
Well, in the Israeli studies, there was a patient who had cardiogenic shock. In another study, there was a patient who died. I believe it was out of Korea. I'm so sorry, I don't remember, but there was a person who just died of vaccine-induced myocarditis that they were able to do an autopsy on. I will say that you are right, that it seems like most of these cases are mild. And that is what I have heard, that this is like transient elevation in troponin, which is a marker of cardiac damage. I mean, that can happen. But it can even happen after running a marathon. So it's important for people to know that can happen. It's rare that it happens for other reasons, but it can. But there are these cases where there's late gadolinium enhancement on the cardiac MRI in these kids. And, talking with John Mandrola, who is a co-author, he's a cardiologist on our paper, that can predispose to cardiac arrhythmia, sudden cardiac death later in life. And I would just say that, when we're looking at these cases reported through the VAERS system, they're all symptomatic. These are these are cases with symptoms. And so we may not be detecting the complete extent to which this is happening. And we also, we don't know. I mean, if it's not symptomatic, I would assume it's less likely to have long-term outcome. But we're kind of like putting the cart before the horse here, because we are mandating that these kids are vaccinated in order to get a public education and to play sports before we even have the full information on the safety data. And we have these trials where we don't even have enough participants to detect this sort of safety signal. There's not enough participants to get severe disease or myocarditis. And then it's like, okay, well, now it's approved. And not only is it approved, but you have to get it for your kid in order for them to be educated. And then it's like, okay, so now the kids are paying the price even more, because, if their parent says, I don't feel comfortable with you being vaccinated, now the kid's paying the price, because the kid's like, now I have to drop out of school. I lost all my friends and my sports and everything because my parent doesn't want me to get vaccinated. So it's like, there's so many levels of badness in this, I feel like.
Yeah. I mean, we got to always think of the unintended consequences of some of our actions, like like some of the mandates. It's like you said, like often, for example, a lot of the hesitant are in racialized communities where they're marginalized already. It's, they're just trying to catch up. And then if you have a parent that is saying no to vaccinate my kid because I had a person reach out recently that kid already had COVID, and they're worried about the myocarditis signal and all these things. And I mean, they're legit questions.
Absolutely. They do appear to be at higher risk of post-vaccination myocarditis if they're already have been infected. And then how much benefit are they getting from this vaccine? That is not answered.
Yeah, that's exactly it. Like, what are we trying to accomplish essentially? Like, is it the risk to the kid? Is it, that's why I've been having a tough time with some of these issues. Like my biggest fear right now is the 5 to 11-year-olds. We're looking at 1,130 kids that have received the vaccine in the Pfizer study, and I'm sure it's gonna be approved. And as you just mentioned, to determine a safety signal based on 1,130 kids or whatever the number, I might be off slightly.
I think it was a larger amount of kids in the 5 to 11-year-old trial. I think it was.
Yeah, it was 2,200 plus that were randomized or that were in the trial, but half of them got placebo and half of them, unless I'm drinking, which is totally possible.
Now I had to look it up as.
You can look it up as that. But from my understanding, it was about 1,100 kids that have physically received the vaccine. It's just what my concern is, as I said, it was like it's hard to be able to find a safety signal based on that in a group that is so low risk, and so luckily, there's reduced dosing. There's which I think will be hopefully a mitigating strategy for side effects. But I'm nervous that they'll mandate it without having clear and without having a large enough pool of kids to really have that evaluation.
Yeah, no, I have the same concern. Yeah, like it was all based on, like the antibody response and the number of cases, which are mild cases. And, it's, I mean, a lot of people have argued like, it's not an emergency. So why are we rushing through that? And through the approval. And, I struggle with that because it's like, well, some kids are at high risk, and I do want them to have access to the vaccine, and I want, parents to, be able to be offered to give it to their kids if they do feel like they're at high risk, or they have someone in their family who's at high risk, who's maybe like my husband's a bone marrow transplant physician. And I do think about like, the kids of those patients. Like I understand them wanting to minimize the risk, but at the same time, it's like, I want parents who feel like their kids are very low risk to be able to make an educated choice rather than being told what to do. And, once again, I think in Scandinavia, I always look to them as like, well, what are they doing there? And it's like, so they are offering the vaccine to the kids, and it's up to them. It's up to the parents and the pediatrician, to decide if they want, to vaccinate the kids. And I think that's the way to go. And you've probably been following along that they're not recommending the Moderna vaccine there, but the Pfizer one because of the myocarditis signal. But
yeah, and it's you put it eloquently. It's a personal risk to your kid. If my kid is at high risk getting sick from COVID, that's a different story, right? Like it's that risk benefit assessment. And this is something that, as the first thing you mentioned when we talked about this on the show, is like, this is a important part of any decision we make in medicine, in life. I'm going to marry my wife. What's the risk benefit of that bad boy? You know what I mean? Like, like it's just, everything is, you got to look at both sides of the coin. And as you mentioned as well, Tracy, like when it came to us, I had no doubt this is the right play for, getting myself vaccinated. And when it comes to my young children, I think I would want to know more data, than we'll say between 1,100 and 2,200 kids evaluated. How about that?
We know COVID has been long and hard, but we can do something amazing together during this holiday season. I'm Kevin Crowe, founder of Give a Mile, and we provide flights for people to be together that are dealing with palliative or critical care. Flights for mothers, fathers, sons, sisters, daughters. And this holiday season, we're looking to give 40 incredible gifts of flights away from November 1st to January 1st. And this is where we need your help. We want to get connected to families that could use these flights. So if you know of a family that could use this incredible gift, please email us at info@giveamile.org. That's info@giveamile.org. And to find out more about Give a Mile, go to giveamile.org. Let's make this holiday season an incredible one of joy.
Kwadwo Nation, sorry, we did take a quick interlude to confirm our numbers, because I believe Tracy was right saying that there was over 2,200 kids that actually did receive the vaccine from 5 to 11. And we also had an interlude because I almost broke my kid's finger by accident there when he put his finger in the door and it was closed, and oh my goodness. But we are back, and so sorry about that. But the moral of the story for me is, as most parents would want to do, you just want to make sure that risk benefit ratio matches up, and hopefully with the reduced dose, and as we see numbers come through, that the safety signal will be there, and because this is our youth.
And I will just say that, even with the, if it's 1,000, 2,000, 3,000, it's actually still unlikely that you're going to find that safety signal that's 1 in 5,000. And it just like they didn't find any severe disease in the placebo group, it just highlights how rare these bad outcomes are, both from the vaccine and from COVID-19 itself. And I'm not trying to make it seem like they're equal to each other, because I realize that if the overall infection and hospitalization rate for a given child in that age group is like 1 in 500, that's not the same as 1 in 5,000. But like we've been talking about, the question is, how much circulating disease is there? Is there a better way to do this in terms of just giving one dose? Or is there, kids who have already been infected, how much do they benefit from the vaccine at all? And, how much in terms of preventing transmission to others, how much benefit are we seeing? Like, that's been really hard to quantify, because if you're now looking, like if you look at the study out of Qatar, I thought that was pretty interesting. Like only 20% efficacy in terms of preventing actual infection, I think it was 5 months after the vaccine. And then in the UK, they've been seeing actually really similar rates of like positive SARS-CoV-2 tests in vaccinated and unvaccinated people now, because it's been many months after vaccination. So we do have to admit that these vaccines are not creating like any sort of sterilizing immunity. Like there's not going to be any guarantee that you're not going to get it or transmit to other people. So, if we had initially hoped that vaccinating kids was going to bring us down to zero COVID, that's not a realistic goal. Also, because I know a lot of people bring up there are a lot of animal vectors that we're not vaccinating as well.
Oh man, that's nuts. I
don't know if you know that they like culled all these mink in Denmark. Like they just killed them all, millions of mink, because they realized that they were infected. This was last winter. I was like, whoa, because they thought that there was going to be like some dangerous mutation coming from the mink. And, now we realize that deer get it, and cats, and I guess even dogs. Like there's a whole list of animals that can get COVID-19 now. I don't know about the transmissibility from them, but
wow. No, but you do bring up good points, like that you could still transmit when vaccinated, but I think there's not to this, we'll assume not to the same degree. It's hard to quantify. The Israeli data, I think, was implying about 50% less risk of transmitting. But I think the mindset we all have to have is we'll be exposed to COVID at some point, but it's way better to have that if with a level of immunity. For sure. The one thing I think would be nice to end off with a little bit was some of the work you've done with sports and reducing transmission during sports. Because I got some boys in hockey, and I know you got an athletic family. So maybe you could talk to us a little bit about that.
Yeah, absolutely. So I did a study with basically like a hockey team, and Allie Krug, another epidemiologist, and it was a select teams, and we were looking at over an entire hockey season, like after there was an outbreak that was associated with a picture night among the teams that eventually ended up tracing back actually to an adult male who reportedly was masked, interestingly enough, like how prevention of transmission, this was before vaccines were available for kids, at least. This was in the winter of 2020, 2021, how we could prevent in hockey transmission. This is an indoor sport. And so we ended up basically being really strict about how many adults were allowed indoors, and that adults did need to be masked, so communicating about kids having very subtle symptoms and getting them tested or keeping them home if they had the subtle symptoms. And then And then the kids, basically, they put on all their athletic gear and got ready, doing everything outside before they came in. So they kind of had everything ready to go before the practices and the games. And then we were able to go through an entire season without any transmission after the protocols. And the kids, importantly, were unmasked during the practices and the games. According to the World Health Organization, kids are not, or no one is actually supposed to exercise wearing masks. And so, that was part of our protocol. And plus we also just found, according to the coaches, the kids were really not able to wear masks during the practices and the games because their goggles were just fogging up and they couldn't see anything. So it really wasn't a practical thing to do. So yeah, we had 148 players and 15,000 athlete hours of exposure. And during all that, the kids were unmasked. We minimized the amount of adults in the facilities, and then had them just gear up and do all the stuff that didn't need to be done on the ice, like outdoors, basically, before they came in. And it ended up working out really well. And there was high community transmission during the time of the study. So, this was an observational study, not a it wasn't a randomized control study. But we were able to, see no evidence of spread on the team, even though some players were found to be positive later after they had practiced. They didn't transmit it during the actual practice or the games. And it's similar to what we had seen like in outdoor youth sports. I don't know if you've seen this study. It was Watson et al. And they were looking at 90,000 kids over an entire summer and playing soccer, none masked. And then there was one transmission event potentially related to the entire summer of soccer. And then also in those same lines, the same group from Wisconsin that did that study, some of the same authors, they looked at high school sports, indoor and outdoor, and the correlation with masking and not masking. And they didn't find any correlation when you control for the community case rates. And so, yeah, it was, it kind of highlights that, at least in our study, if you keep the exposure time down, kids, at least this was pre-Delta, were not spreading it didn't appear they were spreading as much as adults. They were asymptomatic, so less likely to spread that, we were able to keep the transmission. It appeared to be at zero for that entire season. So there, if you get creative and you prioritize doing the right things for kids, you can find ways to do things to minimize risk and still allow them to, play sports and have their normal lives. So that was one of the reasons I was pretty excited about this study.
Yeah, I was excited because you're basically you're adapting to the knowledge that you have. Like, outdoor transmission way less likely. Exposure time matters. So if you don't need to be indoors, change and don't do it. The reason I think it's important to highlight is that if we could use these risk mitigation with stuff that we know is effective, you could win. Especially if it's, I don't know what the future holds in terms of the winter, but I'd rather have these mitigation attempts be put in place than shutting down hockey again.
Yeah, absolutely. We just, it was just like with schools, we have to do what we can, be creative with what we can do. And now we have this incredibly important tool, which is the vaccinations, right? And so now it's if we can vaccinate those that are especially at highest risk, and the adults especially, we really don't have excuses for shutting things down that is, unless absolutely necessary. And again, it's we need to prioritize kids' normalcy over adults. And we've talked about this before. They're the lowest risk, and they lose the most. They lose their childhoods if we're not, if we don't choose to try and do the best that we can for them. So
absolutely. And then they got their whole lives ahead of them, and the stuff that the way we handle this can affect their generation and the next. So I'm definitely speaking to the choir here. And once again, Tracy, just huge props, huge thank you for all that you're doing to really advocate for the kids, to make sure that they have a voice, to treat them well, and educate the public on, hey, are we serving our kids well? Are we looking at the risk benefit of our actions and really thinking, like having that second order thinking of like what is going to happen down the road? And it takes courage, and your husband no longer has to worry, just in case he is a citizen now. Okay. But yeah, Tracy, just much love. Thank you so much for doing this, as always.
Thank you so much. I really appreciate it. I just want to say that, we humans work better together, and, no one alone has all the answers. And so I really appreciate the other people that have been, willing to do the research and try to prioritize kids and get answers and ask the important questions in terms of, are we doing the right thing? What's the best way to do this? And do it in an apolitical way. So we're not, seeing each other as the enemy, but seeing each other as resources so that we can work together to find, the best answer possible. So I just want to thank you and everyone else that has been willing to contribute to that fight. Well,
thank you. I would blush. I kind of am blushing. You can't tell, but I am. But honestly, thanks again.
Thank you.
Kwadcast Nation, tell me we weren't throwing down knowledge on that episode. Thanks again, Tracy. Follow us on Instagram, YouTube, Facebook, Twitter at Kwadcast. Leave any comments at kwadcast99@gmail.com. Check out Solving Wellness, solvingwellness.com, where we're dealing with that's our antidote to clinician burnout. You won't regret it. Leave that 5-star rating, baby. Straight up. Helps with the visibility of the show, allows us to continue to change. Dad Boogie. Thanks so much for listening. We're going to connect again real soon. Peace.